Well, good morning, everyone. The subcommittee will come to order. Another day, another change by the White House to fix their controversial health care law. Today, families and patients abandoned by the new law learned the Obama administration launched a new and improved marketing campaign for the troubled law. It's a strange use of resources, given that the problems are with the policy, not the politics. What's needed are real solutions, not more spin. The Affordable Care Act's fundamental problem can't be fixed with better marketing. The flaw is not the website, the flaw is the law itself. Improving the defective website won't make Obamacare premiums more affordable. Improving the defective website won't prevent millions of Americans from walking to their mailbox only to find the health care plan they have and like is canceled because of the Affordable Care Act. Improving the defective website won't keep President Obama's promise that Americans will see a $2,500 reduction in health care premiums, and won't prevent middle-class families from experiencing more expensive premiums and higher deductibles they simply can't squeeze from their already stretched budgets. And as one fellow Texan wrote to me, we are a family of three that paid $753 a month for health insurance when Obamacare was enacted. We are now paying $1,117 a month for the same plan, a 48% increase. My Democratic colleagues repeatedly promised the Obamacare exchanges would deliver a new competitive marketplace that made it easy to shop for insurance. But the reality is far from that. Of the several thousand counties served by the federal exchanges, over half have plans offered by just one or two insurance carriers. In about 530 counties in America, families have only one choice, just one insurer in the exchange. So fixing a defective website won't create competition and choice where none exists today. Now our small businesses have been told that the online shop exchanges they were told would come on, that they could count on for affordable health care options, has been canceled for next year. Does fixing a defective website restore that broken promise to our local businesses? We are all hoping for the best, but that November 30th deadline to fix the website problems has passed, and no one yet knows if the system has the capacity to enroll, accurately determine subsidies, and complete a new insurance policy for all the millions of Americans abandoned when their policies were canceled by the President's new health care law. To do so, the new improved website will need to enroll close to 100,000 people per day, every day this month. And that's how many who selected a plan in all of October. Regrettably, at this point, the American public has little confidence the website is ready for prime time, and this latest promise will be kept. The clock is ticking. We are right in the middle of prime time for individuals, for families, and small businesses to find affordable health care that begins on January 1st. What will these patients and families do when they show up at the hospital or need to reorder a life-saving prescription on New Year's Day and their Obamacare plan isn't yet available? This coverage gap is real, and the White House has said it has no plan B to prevent this frightening problem. Looking forward, the flaws in the law itself may prove to be getting worse, not better. The young and healthy are not signing up, which is bad news. In Connecticut, for example, 61% of the enrollees are between the age of 45 and 64. In California, 56%. And that's double their proportion of the state's population. But without the right mix of the young and old, healthy and sick, health care premiums for 2015 will skyrocket. Access to care will become more limited, and insurers may no longer offer coverage. Plus, the mandate on local businesses slams into effect in 2015, forcing local companies to consider cutting hours or workers or health care benefits to comply with the onerous law. Today's hearing is not about a new and improved marketing campaign. It's not merely about a defective website. It's about the real-life impact of a law that is not living up to the promises made to the American people by President Obama and my Democrat colleagues. Before I recognize Ranking Member McDermott for the purposes of his opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objection, so ordered. I now recognize Ranking Member Dr. McDermott for the opening statement.
Thank you, Mr. Chairman. I want to welcome all our witnesses, and especially my fellow Washingtonian Congressman Kreidler, now Commissioner Kreidler. As we look at the progress of the Affordable Care Act, I'd like us to remember how we got here. With the way we talk about the ACA, one might wonder why we ever abandoned the old system. in the first place. I'll tell you why. It was unhealthy, it was unfair, and it was unsustainable. Healthcare costs, one of the largest contributing factors to our national debt, were out of control. People were going bankrupt. The cost of providing care to the uninsured added an extra $1,000 a year to each family's household bills through higher taxes, premiums, and healthcare costs. Coverage was dropped when customers needed it most, and over the country, those with pre-existing conditions were just out of luck. So let's keep those conditions in mind as we discuss our progress. It wasn't the Democrats that wanted a better system, it was America. Are we as a society better off now? The answer is a resounding yes. We've made huge improvements in the system. It hasn't been perfect, and I'm sure we'll hear some interesting and upsetting testimony today about our witnesses, from our witnesses, though what I've read, many of their assertions are unreliable, if not untrue. Even with glitches, the ACA reforms are making the insurance industry more accessible, fair, and cost-efficient than ever before. Looking at our progress, I'm less concerned about websites than the reality that we are creating two separate Americas. While one half of our country moves ahead with affordable health insurance, the other half is being left behind. Places like Indiana, Georgia, Florida have chosen not to expand Medicaid, leaving hundreds of thousands of the people who are most vulnerable with no help available. Texas has over 1 million people that could be insured at no cost to the state if the governor chose to expand Medicaid. Instead, Texas, who need it most, the working poor, families on minimum wage, and veterans trying to get back on their feet get nothing. It's hard to imagine a reason for this other than simple spite. It's cruel and fiscally irresponsible. Hospitals in these states will lose billions of dollars in revenue as they provide more uncompensated care. Instead of accepting $500 million federal dollars, Mississippi has transferred $4.4 million from its state budget, including education funding, to pay hospitals for uncompensated care. Some hospitals have had to close facilities and service lines. And if that weren't enough, Republicans are urging constituents to turn down affordable care. Oklahoma has filed a lawsuit arguing that Oklahomans are not entitled to the tax credits through the exchange. Tennessee, among others, is trying to create penalties to make it as hard as possible for churches and nonprofits to help people sign up. A good Samaritan, even a friend or a neighbor caught, quote, facilitating enrollment, close quote, without being vetted, fingerprinted, and registered with the state could be fined $1,000 for each offense. All this to make the president look bad. Now, fortunately, we have an unbiased witness here today who's actually making this all work. Commissioner Kreidler can speak directly to what happens when a state cares about its people. He has actual experience in the front lines of implementation. Washington State has reached nearly 175,000 enrollments through our state exchange, and those numbers are growing every day. Our exchange is robust, and with the exception of a few issues, has run pretty smoothly. I had a constituent call my office, irate that his insurance company had canceled his plan and offered him a new one at double the price. The next day he called back. He went to the exchange and found a better plan with his old insurance company for less than he was paying before. As the home of companies like Microsoft, Amazon, Starbucks, Washington State knows about launching big projects. The Boeing 787 wasn't built in a day. Success doesn't come without bumps. It takes commitment, it takes investment, and patience. If Bill Gates had stopped at the first hiccup, where would the personal computer be today? We knew this wouldn't be easy, but it's worth it. And this is the reform that America wants and needs. I yield back.
Thank you, Dr. McDermott. Today we will hear from 4 witnesses: Grace Marie Turner, the founder and president of the Galen Institute; Dr. Scott Gottlieb, resident fellow at the American Enterprise Institute; Chris Carlson, principal at Oliver Wyman Actuarial Consulting Incorporated; and I would like to turn to our ranking member to introduce our 4th witness.
Thank you, Mr. Chairman. I mentioned Commissioner Kreidler. He was a member he came in the sweep of '92 when a lot of Democrats came in here and the Clintons were elected and we thought we were going to have health care. And he was here to work on that. He and I had worked in the legislature for a number of years on this whole issue and put together the Washington Basic Health Plan and other things. 2 years later, he was back in the state of Washington doing other things after the failure of the Clinton effort. He since then has become the longest sitting insurance commissioner, elected commissioner in the country, and knows all the ins and outs of this issue, and it will be a good witness today for people to find out what happens in a state where they went from the first day to make it happen, and they've done a very good job. So it's my great pleasure to introduce Mike Kreidler.
Great, thank you, Doctor. Ms. Turner, you're recognized, and we've reserved 5 minutes for each of the opening statements.
Thank you, Mr. Chairman. Thank you, Chairman Brady, Ranking Member McDermott, distinguished members of the committee, for the opportunity to testify today. All eyes have been focused recently on the website, but there are many challenges that I'd like to talk about that are in store that it will impact tens of millions of Americans who are not affected directly by the law, according to the President. He says 85 to 90% of Americans who already have health insurance, for them, their only impact is that their insurance will be stronger, better, more secure than it was before. They don't have to worry about anything else. But that is really not their experience. I will focus primarily on the impact on the 150 Americans who have coverage through their employers. Employers have been providing health insurance voluntarily for more than 70 years. They see it as a way of attracting good workers, but the ACA places significant burdens on them that's really forcing them to rethink their arrangement. Small businesses are hit especially hard. An estimate in the June 2010 Federal Register predicted that up to 80% of small business plans could be lost because they don't comply with the ACA's requirements. Many employees will find that their new ACA-compliant coverage is more expensive and less attractive, higher premiums, higher deductibles, and narrower networks. The Congressional Budget Office estimated that as many as 11 million workers could lose their health insurance simply because their employers find that they have no choice but to pay the fine and drop their health insurance coverage. The American Action Network suggests the number could be as high as 35 million people in small businesses primarily. Many employers also are being forced to cut hours so that they can stay under the 50 full-time employee cap. This is a significant income loss, obviously, for the employees, but it's also a painful decision for employers who really want to keep full-time workers and disruptive for their businesses. I've spoken with the owners of many small businesses who say that the $2,000 to $3,000 fine would basically consume their entire profit margin, not just providing health insurance. And the one-year delay really isn't helping because they have to plan longer term for their business planning. The delay in the shop exchange was that the chairman mentioned is yet another blow to them. I describe in my testimony, my written testimony, many of the new taxes and other mandates and penalties that employers face. In particular, the tax on individuals, the $63 per person tax that adds the cost of every health insurance policy, the tax that will cost families an additional $360. These add taxes and no new benefits, and it's simply pushing up the cost of coverage. Susan McCarrick, who is head of human resources at the University of Virginia, described what her choices are. She said, when medical expenses go up, which they have and which they are, we can either increase premiums or we can reduce what we pay out in the way of benefits. She said the law is expected to cost $7.3 million to the University of Virginia's health plan in 2014 alone. In addition, of course, millions of people with individual policies are really among the first targets of this law. They are losing their coverage. 5% of Americans represents 15 million Americans that we think we really must attend to or are having a difficult time finding coverage. I do believe that there are some near-term policy fixes that are going to be required. The House passed, of course, the Keep Your Coverage Act. The Senate has a similar measure that Senator Johnson is offering. And I think that if we could encourage the Senate to take that up, we need to give people a chance who have coverage that they like, who can't get onto the exchange, who find the exchange coverage is more expensive, that they find that they're able to keep their policies. Secondly, and I think this is crucially important, those who are on high-risk plans now, either the 200,000 or so who are on the 35 state high-risk pools, many of which are being closed, or the about 100,000 who are on the federal temporary high-risk plan, are desperately trying to get new coverage. Many of them have chronic illnesses. They're in the midst of chemotherapy. They have a child with significant health problems. They need some place to go for coverage. And I strongly encourage us to think about what we can do to extend those high-risk programs to make sure people who desperately need care are not forced to leave coverage. I see my time is up, Mr. Chairman.
Yes, thank you, Ms. Turner, very much. Dr. Gottlieb?
Mr. Chairman, Mr. Ranking Member, thank you for the opportunity to testify today. My name is Scott Gottlieb. I'm a physician and resident fellow at the American Enterprise Institute. I previously served at the FDA and CMS, and I also sit on the policy advisory boards to the Society of Hospitalist Medicine and Leukemia and Lymphoma Society, as well as being a clinical assistant professor at the NYU School of Medicine. In time, the existing parts of this website will be fixed, but more significant challenges remain related to issues around provider access and the quality of the medical care. I fear many consumers who enroll in these plans will find themselves disappointed by the resulting health plans, or worse, get caught in difficult financial and medical binds. And I want to focus on three significant but remaining challenges that I believe will lower the quality of the resulting care and hinder consumer access to needed medical services. I believe there are steps we can take today to mitigate these challenges, but unless we act quickly, the law does not provide flexibility to address some of these problems. First, the information infrastructure required for reconciling someone's coverage with his health planner, his providers, has not been constructed. In some cases, it simply does not exist. As a result, it's likely that there will be delays in enabling premiums to be collected and paid to health plans, and in turn, health plans are likely to withhold payments to providers. People signing up for coverage may not, as a practical matter, be covered starting January 1st. This needs to be addressed by Congress immediately to avoid significant potential hardships. Second, it's now well established that more than 50% of the plans sold on healthcare.gov are narrow network options that offer very limited choice of providers. I don't think the full scope of how restricted these networks have become is fully appreciated, or the extent of the cost that will get transferred to patients. This is going to put particular hardship on patients with special medical needs or serious illnesses. And once again, the statute and regulations do not afford easy ways to mitigate these challenges. To give you some context for how this is playing out at a practical level, we're providing from AEI today some data we developed on Blue Cross Blue Shield, one Blue Cross Blue Shield plan that operates in 9 different states. We compared the exchange network to their commercial individual market PPOs for 6 categories of specialists. We consistently found that the exchange-based plans offer just a fraction of the specialists available in competing non-exchange PPOs, and we looked at the most populous counties to give them the best chance of coming out ahead. Among some of our other anecdotal findings, we found a plan in Florida that currently has only 7 pediatricians in its network to service a county that has 260,000 children, according to census data. In San Diego, we found a health plan that doesn't have a single pediatric cardiologist in its network. In San Bernardino County, we found a plan with the nearest urologist that was offered was 80 miles away, and the same plan has 9 dermatologists in it, but none of these doctors seem to perform Mohs surgery for skin cancer, and most of them are at least 100 miles away from the county. The problems are made worse by incomplete oversight that's been applied to resulting plans. Review of plan design network adequacy was rushed and done poorly. With lax oversight, there's a risk that plans can inadvertently or sometimes intentionally game the risk pool by their choice of providers and their design of networks. And finally, keep in mind that these narrow networks do not just affect providers. The same constructs will also hamper patient access to specialty drugs. If you're on a non-formulary medicine, you could be saddled with much or all of the cost of the medicine. This is going to be a particular burden to patients with significant conditions like cancer. These costs won't count against out-of-pocket limits, deductibles, or lifetime caps. Third and finally, there's already evidence that providers are reluctant to sign contracts with the Obamacare plans, and when they do, reimbursements being reduced, even off the levels that were initially negotiated under some of these contracts. There should be every reason to expect that the same sort of problems with access and quality that challenge the Medicaid program will also challenge Obamacare. People People who will make out worse under Obamacare seem to be getting short shrift in a lot of the policy discussions. There seems to be a perception among some that these folks are mostly wealthy or upper-middle-class families. That's not entirely true. Many of these families are solidly middle class and many struggle financially. Nor are the misperceptions of their relative wealth an excuse to ignore their plight. The fact is that in aiding those who were burdened in the old insurance markets, and some people will clearly be helped under Obamacare, it didn't require us to harm those who were doing reasonably well under those old structures. And even those who were previously uninsured or only intermittently insured will find many of the bronze plans that they're being incentivized to join providing lower quality access. Thank you.
Thank you, Doctor. Mr. Carlson?
Good morning, Chairman Brady, Ranking Member McDermott, and members of the subcommittee. My name is Chris Carlson, and I'm a Principal and Consulting Actuary at Oliver Wyman. I would like to thank you for affording me an opportunity to share my perspective on the Affordable Care Act. My testimony will focus on the consequences of the difficulties encountered in implementing the ACA. The specific issues that I will address are, first, the enrollment issues, which have led to initial enrollment in individual policies falling well below original estimates. Second, the extension of current individual policies that do not meet the requirements of the ACA's minimum coverage requirements. And third, I will discuss the premium rates that are available to individuals on the exchanges. First, regarding the low initial enrollment, it is too early to make any speculation about the final enrollment numbers for 2014, but given the low enrollment numbers that we have seen, there's an expectation that the enrollment will be less than expected. In fact, Goldman Sachs and Company has revised down projection estimates of the federal exchange enrollees from 7 million to 5 million. Also, early indications are that the younger enrollees, who are crucial to the goal of having a balanced risk pool, may be enrolling at rates less than expected. If younger individuals do not enroll at the expected levels, the subsidies that are built into the rates that allow for premium rates to be lower at the older ages will not be realized, putting a strain on the overall risk pool. Next, I will briefly discuss the President's use of non-enforcement of existing law to allow for the extension of current policies that do not meet the minimum coverage requirements under the ACA. There are a number of potential outcomes that could result from this extension. First, studies prepared by the Society of Actuaries show that those currently insured in most states have better morbidity risk than the new enrollees expected for 2014. Therefore, it was expected that premiums would go up because of this increased morbidity risk. Furthermore, many current policies do not provide sufficient benefits to meet the minimum coverage requirements of the ACA. Therefore, individuals who are currently insured in less than sufficient policies would see further increases due to an increase in benefits for the exchange policies. While this generally is a trade-off between premium for additional benefits, those opting to drop current less generous policies are those that are likely to need that additional benefit coverage. Both of these factors lead to an expectation that the pool of members enrolling in the ACA qualified plans on the exchanges will have higher morbidity risk than if the extension of policies was not allowed. In addition, since insurers have not been given the opportunity to revise the premium rates on the exchanges, it is likely that these policies will be underpriced. As a result, we have seen hesitation from some state insurance regulators to allow for the extension of these policies. It is too early to provide any empirical data to estimate the impacts of these changes on the expected costs for 2014. However, the American Academy of Actuaries has identified 3 primary consequences of the extension of current policies. 1, premiums for 2014 may not adequately cover the cost of providing benefits for an enrollee population with higher claims than anticipated. Costs to the federal government could increase as higher than expected average medical claims are more likely to trigger the risk corridor payments. And third, relaxing the plan cancellation requirements could increase premiums for 2015. Insurers cannot increase premium in future years to make up for prior losses. However, assumptions regarding the composition of the risk pool would reflect this plan experience for 2014. There's been much written and said about the premium rates on the exchanges. Depending on the point of view, premium rates are either much higher than expected or much lower than expected. However, I will repeat what was said in the hearing of the House Energy and Subcommittee on Oversight Investigations by Corey Uccello, an actuary, of the American Academy of Actuaries. How premiums will change depends on many factors: the new benefit requirements that may lead to higher premiums but lower out-of-pocket costs, how each state's current issue and rating rules compare to those beginning in 2014, and each individual's demographic characteristics and health status. All of these things remain true. I will highlight a couple of these items that merit specific attention. First, individuals who are seeing the greatest increase in premiums are those who had the least amount of coverage. Therefore, the additional premiums for additional benefits. Second, any consideration of the increase in premium rates is considered prior to the availability of the premium subsidies, which would reduce the actual out-of-pocket costs for individuals. That concludes my oral testimony, and I thank you for inviting me, and I look forward to answering any questions.
Thank you, Mr. Carlson. Congressman Kreidler, welcome back.
Thank you, Chairman Brady.
Can you hit that microphone in front of you?
There it goes.
Perfect.
Thank you, Mr. Chairman, and Ranking Member McDermott and committee members. I'd like to try to cover a couple of topics here: the challenges that we have in the state of Washington, how it's currently working in the state of Washington, and the need going forward for collaboration. My name is Mike Kreidler. I am the Washington State Insurance Commissioner, and in this capacity as Insurance Commissioner for the state of Washington, I've had lots of conversations with people that contact me. We get 100,000 phone calls a year through my office. Over the years, it's become clear that there were a lot of people out there that were really hurting, where with limited access to health insurance, it was either unaffordable to them, or they'd find out the existing policy they had when they had a major incident in their life, having bad luck that their policy was significantly inadequate to meet their needs. What I see right now with the Affordable Care Act are the tools that we need in order to help make sure that people have access to health insurance that's affordable to them. And that's partly because of subsidies that are available to them, also increased access in the state of Washington to the Medicaid program. All of these are making it possible to help. If it isn't the Affordable Care Act, then let's name something else that's going to accomplish essentially the same purposes as the Affordable Care Act. Washington has significant problems with the current system without the reforms. We've got over 1 million people that are without health insurance. And in addition to that, we've got 200,000 to 300,000 people who do have insurance, but it's inadequate insurance, meaning that when they have a medical crisis in their lives, it's not going to meet their needs, such things as pharmacy coverage. 80%, approximately 80% of the individual market in the state of Washington doesn't cover pharmaceutical, much less maternity. Going forward, as we look at the Affordable Care Act, there's a lot of people that refer to it as somehow a government takeover of our health insurance system. This is built on the private insurance system. It's built on what I saw when I was a member here, Mr. Chairman, that was put forward with the Dole-Chafee bill that had 20 Republican sponsors in the Senate on it. It's very comparable with the philosophy that came forward with the Heritage Foundation in the late 1980s. It really is not a Democratic proposal. It is built on the private insurance system. Now, Washington does have an exchange that's up and operating. It's enrolling, as Ranking Member McDermott pointed out. We've got 100,000 people enrolled, 175,000 people who are queued up right now to be enrolled. It's proceeding quite nicely. And for those reasons, I said no to the opportunity to extend existing policies. It would have been very disruptive, as Mr. Carson pointed out, to our market if we had allowed that to take place, because the Affordable Care Act is working in the state of Washington. I know that we've had some problems, whether we talk about the canceled policies or whether we're talking about websites operability. Those are challenges, and those are good things to bring up. But it's also important to take a look at major programs historically, whether it's Social Security, whether it's Medicare, or whether it was the pharmaceutical benefit under the Medicare program. They all had challenges as they started up, particularly when we look at the pharmaceutical program and some of the problems they had. I saw that because I was the insurance commissioner at the time. What I would like to urge people to do is to be patient. This is in the early stages of enrollment. Don't just look right now and say, this issue right now is an impediment. The headline of the day is not what we need to be doing, is being patient and going forward. Focus on the benefits of the Affordable Care Act to consumers. If you can take the name of Obama out of Obamacare and just focus on the benefits, you find the benefits are widely popular in virtually every district in the United States. Rome wasn't built in a day, and I can tell you right now the problems we have with our current existing healthcare system didn't occur in a day. We need to be patient, move forward, focus on enrollment. But the enrollment is only in its early stages at this point. States like mine need you. I would urge you to be a critic. That's fair, that's reasonable, it's expected, particularly from the party that did not advocate for the Affordable Care Act. But at the same time, we need to solve problems, because going forward, we're talking about people that are hurting. We need to make changes, not just for these people, but also to address the challenges for the U.S. economy if we don't make these changes. Thank you, Mr. Chairman.
Thank you, Commissioner. Congressman, appreciate your testimony. One, congratulations on running a model exchange. Two things stand out. One is that you did testing, extensive testing of your website and exchange before the deadline hit. I wish Washington would have followed your lead, because this has led, despite repeated assurances to this committee and all of Congress, both parties, that was not done. And the second thing that stands out really drives my first question, which is the coverage gap. You're running as good an exchange as exists in America, yet so far have only signed up a fraction of those in Washington State who've received cancellation notices. We're all concerned about a potential coverage gap on January 1st as a result, again, of this defective rollout. So, Ms. Turner, let me start with you. How significant could that coverage gap be for families in America? How significant could it be that families show up on New Year's Day in the hospital needing that life-saving prescription and find that what they signed up didn't actually make it all the way through the process? They don't have that coverage. How concerned should we be?
100% concerned. It is absolutely going to happen. When we have a deadline of December 23rd for people to enroll, and all of that paperwork has to be processed, and people think that their coverage will start on January 1, I think it's impossible for everyone that signs up by December 23rd to get coverage and to have that work through the system. In particular, we see that the data that's coming from the federal hub, from the federal website, for the 834 forms are inadequate and wrong. At least a third of it is inaccurate. And so I think it is a huge, huge concern that people are doing their best to try to sign up for this coverage and are not going to be able to get through the website and be able to be signed up, and may even worse think they are and have it not be processed.
Thank you. Dr. Gottlieb, you, in your testimony, point out something I don't think anyone's focused on, which is the payment gap, the part of the process where after you enroll, in your testimony, you say the system to ensure that our local health care providers are being reimbursed does not yet exist in the system. Could you talk a little more about, and why should we be concerned about that?
Well, the issue is whether or not people who think they've enrolled in a plan on the exchanges are actually enrolled in those plans. If the information, we know that the back end hasn't been built yet, and we know that the subsidies that should flow to the insurers aren't going to flow to the insurers appropriately or on time. And so the question becomes, what do the insurance plans do if they don't have someone either appropriately enrolled in their plan or that they've been paid for? And while I think they're going to be hard-pressed not to honor the contract that they, or the, purported contract they have with that consumer, I'm hard-pressed to believe that they're going to allow money to flow to providers when they haven't been paid on those policies. They're going to hold up those payments. It's not clear exactly what they're going to do, frankly. That's why we should be thinking about this and worried about this, because people are going to start to try to access care in January. and either the providers aren't going to get paid on time, and they could very well drop out of these plans, or the contracts might not be honored at all. Now, I know the administration made an announcement last night that they're going to effectively guarantee those payments. I don't think that fully resolves this problem, because it doesn't resolve the issue of what the insurers are going to do with the providers when they haven't been paid yet. They haven't either received the premiums, appropriate information to enroll the beneficiary, or haven't received the subsidies.
So if Washington doesn't pay its bills on time, the insurance company, they're going to be in a bind in paying those local doctor bills and hospitals as well. Is that?
That's right. I mean, we've seen the insurance companies do this in the past. If they're not getting paid, it's a reasonable expectation that they're not going to let money flow out to pay bills.
Yeah. I don't think many of us are worried about the insurance companies. We're really worried about the process of does that local doctor, are they assured that they're actually going to see reimbursement? And I think that's the concern.
And they might, and if they don't, they might not continue providing care. They might have to drop out of these contracts, and it's just going to further strain the access issue.
Well, let's talk about that. Let's talk sort of about the doc shock, which is maybe after sticker shock, maybe our biggest challenge for our families, which is, in your testimony, you pointed out that many of these plans are very narrow network. And so the affordable ones, or at least those with the lower prices, so a family may find they can't see a doctor that they've seen, or they see multiple doctors, can't see both, a local hospital or provider, and so may well be forced out of network. And in your testimony, you make a case that when that occurs, not if it occurs, when that occurs, that patient may be required to carry the entire cost of that treatment, and it won't count toward their deductible or out-of-pocket caps or any of that. So, in effect, you're saying they almost are going to see an HMO experience with them paying extremely steep bills under these plans. Is that correct?
Well, that's exactly right. I think if you know, conceptually, in the 1990s when HMOs were first introduced, people rejected them. We had the Patient's Bill of Rights introduced into Congress, and most consumers demonstrated that they preferred PPO-style plans, which afforded flexibility on providers, and they were willing to trade away some benefits and higher copays and deductibles for that flexibility. I think what the Affordable Care Act really does is force us back into that old option, the HMO-style option, where you're trading away the flexibility in favor of this government-guaranteed benefit package, and really not lower copays or deductibles. I mean, the copays and deductibles are fashioned off of catastrophic plans here, so they're still quite high. But it's a foregone conclusion that you won't be able, if you have multiple doctors, it'll be very hard to envision patients being able to keep their full complement of providers. Now, the fact is that it's very hard to get a handle on what these networks look like. We tried hard, and a lot of the networks aren't even formed yet, which begs the question how these plans even got through the review process at CMS. But that said, they're not even formed. So patients are enrolling in plans where they really don't know what the full network is. We did a study, we put out an analysis on Anthem Blue Cross Blue Shield, and frankly, we chose that plan because they're the most transparent. I mean, they provide their full network not only for the exchange-based plans, but also for their commercial market. Also, they're highly regarded, so we dealt with one of the better plans. And we picked the most populous county in each state that we looked at and looked across 6 specialty areas. And the numbers were pretty grim, and I think that this represents the high watermark. I mean, this is probably the best you're going to see. When we looked at Molina Health, for example, a Medicaid plan, it looked far worse, but it was much harder to get data because the network information wasn't available in all the states. But this is going to present a lot of challenges to patients.
Could that doc shock also apply to medicines? You know, if you're a patient using either new or specialized medicines, could that formulary also be narrower in those plans so that you're faced with the same very high out-of-pocket costs that don't apply to any of your deductibles or caps?
Yeah, well, it absolutely does apply to medicines. It hasn't been as acute of an issue so far, one, because people haven't tried to tap the insurance, and two, because a lot of the states benchmarked off state plans that had reasonably good formularies. But if the drug isn't on your formulary, then you're going to have to pay out of pocket for it. And again, the coinsurance applies. You could pay all the money out of pocket. So you could be out a lot of money. Now, there's a way to appeal to CMS to try to get that overturned to get the drug paid for. But most patients aren't going to be able to go at risk if it's an expensive cancer drug, for instance. First of all, they're not going to be able to go out of pocket for the 3 or 4 months it might take to appeal. And even on a risk-adjusted basis, even if their doctor says, look, there's an 80% chance I'll win the appeal, that 20% chance might be too much for them to take because the money would be so substantial that they would be forced to pay. So I think that this will be prohibitive. Where this is going to become a much more acute issue, first of all, some states that don't have good model formularies, but also going forward, new drugs, it's going to be slow to see new drugs introduced into those formularies because of the process that's being put in place. So access is going to be inhibited for newer therapies as we go forward and as these formularies should adapt over time to new treatments.
Right. I think it's an important issue. It hasn't been highlighted much, but is a real concern for the families that don't fit into the box, as Washington likes to do. You're right about the uncertainty back home. I met roundtable with our local hospitals. One of them, they don't know which plans they're in. One of them has figured out they're in 23 of 56 plans in Texas. Two of the other hospitals had no clue what they're included in. The doctors talked about really the return of the HMOs. One of them sort of jokingly called this HMO Obamacare because of those narrower networks and the concern that those out-of-network costs will be so high. Let me ask, you know, aside from the sticker shock and potential doc shock our families could face, the testimony today we saw really lays out next year sort of an aftershock to where we are right now. Because the enrollment problems, because the mix of those who are enrolling, that our families may well face much higher premiums next year, and the mandate that our local businesses offer this. Mr. Carlson, can you address that for a moment?
Well, I mean, I think it's been clear in some of the statements the actuarial community has made that there is a lot of forces that are changing premium rates. And, obviously I speak of this prior to any consideration of the premium subsidies. But, most of the changes in the benefit requirements and most of the change, you have the insurer fees and those other factors that are driving up the premium rates. And then when you look at the gender rating and other market reforms, again, specific populations that are targeted there create a premium rate increase for that particular population, for example, younger individuals. So, that is a concern to individuals buying insurance on the exchange. Now, another concern, and I talked about it in my testimony, we need to get our premium rates filed by, sometime at the end of spring or toward the end of spring. By then, we're going to have very little information to work with. So, if our enrollment is not enough to provide any valid data, again, we're going to be kind of, I don't want to say guessing, but having to make some pretty significant assumptions about what premiums are going to be in 2015, which makes our job a little more difficult. And, if the risk pool is not a broad and balanced risk pool, that's going to put upward pressure on the premium rates for 2015 as we try to work with the data we do have.
And I think that's the point. One, to be fair, we need to allow the White House to finish their push to see what that enrollment mix will be. But I think the point we've heard today in a number of the testimonies that if the younger don't sign and healthier don't sign up significant amounts, if the White House misses the $7 million goal significantly, it could well lead, depending on that mix, to higher rates in 2015. Well, thank you all very much for the testimony. Dr. McDermott.
Thank you, Mr. Chairman. As I listen to this testimony, there's two countries. There are those states where they put up a state exchange, and then there's all the rest that sat back on their hands and said, let the federal government do it so we can throw rocks at them later because it ain't working. And Mr. Kreidler, I would like you to talk about how you got bipartisan support to put together and begin a long time ago. Nothing that we've heard testified here today is unknown. It has been known for 3 years. So you knew in 2005 that you were going to have, or 2009, you would have certain problems. And you started working on them, the narrow networks and all the rest. I'd like to hear how you went through the process of putting together an exchange that works.
Thank you, Congressman McDermott. Let me say, that I sit as a board member of the Health Benefit Exchange in the state of Washington. And as such, I can tell you right now that the makeup of the board looks like a rainbow coalition, so to speak, of political views. We don't always agree on the best course of action, but we always have our primary focus and interest is making sure that it works, that people have access to health care, that it's affordable. And from the standpoint of looking at the networks that are out there right now, that's been a job for our office and inside the exchange. Obviously, one part of the change that we're seeing right now are narrower networks. And as a part of that right now, we are taking very seriously to make sure that if there is a problem from the standpoint of making sure that there's an essential benefit and it's not in part of the network, that they will be treated as in network and from the standpoint of the patient and the consumer, so that they wind up getting the benefit of the doubt when they do have those exclusive types of benefit, whether it's cancer treatment or whether it's hemophilia or whatever it might be. We make sure that they're going to still be, if the promise has been made in the policy, we're going to make sure the insurance company lives up to that promise. So we're working to endeavor to make sure that that happens, so that as we go forward, we see health carriers that are playing a much more active role now in plan management, something that all of us thought was really important going forward to see that that happened, and we're starting to see it right now. We want to make sure that it is not something that disadvantages the consumer. And from the standpoint of services that can be bought competitively in the market, that are comparable quality and outcomes, that's desirable if it offers a better price and reasonable access. Access is what we are concerned about. We want to make sure that policy performs and offers the access that's been guaranteed in that policy, and we're going to work together to make sure that happens, whether it's through the exchange or whether it's outside of the exchange, because all of the plans in the individual market and the small group market have to meet the same standards, whether they're in the exchange or outside of the exchange. And we've got a lot of plans out there, a lot of carriers, and we offer some real opportunity for consumers.
Dr. Gottlieb talked about the fact that doctors might not get paid or that somehow payments would be held back by insurance companies. Have you ever had a complaint to your office from a physician's office that the insurance company wasn't paying their bills?
We've had, Congressman Retorno, we've had lots of complaints about that over the years, well before the Affordable Care
Really?
Act.
Before Obamacare?
Oh, way before Obamacare.
Oh.
And that's always been an issue. And when we hear those complaints, and it's a fully regulated plan that we have authority over, we contact that company right away, and we make sure that they are living up to their promises, that they're paying on those claims. If there's a problem out there, we're going to go after that carrier to make sure that they're complying. And quite frankly, we've received a remarkable amount of good faith work with the health insurance carriers in the state of Washington when we bring it to attention. Everybody makes mistakes. They can make mistakes as well as anybody else, and when they do, they're quick to make the correction of that. So I don't look forward to them holding back. Now, again, we're talking about a state-driven exchange. We didn't cede the power to the federal government. We said we wanted to make sure our plan worked to the benefit of Washington consumers, that it wound up being styled to what we are used to in the state of Washington. So we took control of it. We did not defer to the federal government. So it made a big difference.
Could I just ask you to talk a little bit about the change? In my understanding, insurance regulation has always been done at the state level. Federal government has never put its hand into it before. Now we're putting our hand into it, sort of. I don't know exactly how it feels or what it looks like. Tell me, I mean, some states clearly have insurance commissioners that aren't doing their job. But the question I have is, what's it like to have us start telling you what to do?
Well, to some degree, we've already had some of that because of ERISA and HIPAA and some of the other standards that were out there well before Obamacare. But we had some guidance from the federal government. When it came to regulation, you're absolutely right, Congressman McDermott, that we have been, for the fully insured market, the ones that have been in charge of this, so that we have been driving it at the state level. So that is something that we're used to. As we look at the federal involvement right now, it is one that provides some bottom line guidance so that there aren't lowballers out there, that consumers are protected, they get the services they want.
Thank you, Commissioner. Mr. Johnson?
Thank you, Mr. Chairman. Dr. Gottlieb, you mentioned in your testimony it's been reported that the focus has been to fix the website registration process, but that means insurers are still getting faulty reports on individuals who believe they've signed up for coverage but aren't actually enrolled. Yesterday, the Texas Health and Human Services Commissioner sent a letter to Secretary Sebelius stating he has serious questions about the validity of the data we've received from CMS. While electronic account transfers have been delayed, CMS has provided states with spreadsheets of individuals the marketplace determined would be Medicaid or CHIP eligible as of January 14. Our review of the spreadsheets for Texas found individuals with addresses from other states, including as far away as New York, fields that were left blank, and people who are already receiving Medicaid or CHIP. Given all the problems and mistakes that are still ongoing, how can the federal government force people to buy a product they don't want? One, and businesses have been given a year reprieve from this onerous law. Shouldn't individuals be treated fairly and be given a delay from this complicated mess as well?
Well, I'm one who believes that at some point the administration will announce that they're not going to enforce the individual mandate, and they'll just wait perhaps until after the enrollment deadline. I find it hard to believe that they're going to enforce a penalty on people in a situation where it's, nearly impossible in certain situations to sign up, and certainly difficult. So yes, I don't think there should be an individual mandate. We should also keep in mind that since the data being transmitted to the plans is wrong, a lot of that revolves around determination of eligibility for the subsidies. So it's fair to assume that some of those subsidy calculations are wrong, and it's also fair to assume that you're more likely to enroll in a plan if the subsidy calculation is wrong in your favor than against you. And so there's going to be a percentage of people, and it could be potentially high, who were told they were eligible for subsidies and enrolled on the basis of that assumption where those subsidy calculations were wrong. It's unclear how that's going to be handled, whether that money is going to be clawed back or there's going to be some kind of grace given for this year if the mistake is on a part of the website in the federal government. But I think it's fair to assume that, and who knows how big the number is, that there's a certain percentage of people who enrolled who have wrong calculations.
Yeah, well, maybe we need a delay to figure it all out. Ms. Turner, I want to do just a simple comparison. Let's compare what we know about 2014 to what will happen in 2015. One, will premiums be higher or lower in 2015 than 2014?
I think we've heard that it greatly depends upon all the young, healthy people signing up for coverage and getting the 7 million enrolled. That looks increasingly unlikely. And I think if we start to see enrollment decline, you get the exchanges become basically high-risk pools instead of the broader plan, that you're going to see premiums only go up, and I think that's going to significantly impact enrollment in 2015.
Yeah. Well, will individuals have more or fewer choices of doctors?
And as Dr. Gottlieb has shown in his new study, across the one plan that he was able to get good data on, that we see that the choice of physicians is dramatically reduced, and the limited networks are really a result of trying to have so many benefits in the plan. But providers and especially hospitals are very limited.
In your opinion, will more or fewer insurers participate in the exchanges?
If I were an insurance company, I would be looking very carefully at this and thinking, if you didn't get in one of these exchanges, you're thinking, I am so glad. And I think they're going to look very carefully.
Stick. Will insurers expand or decrease the number of counties where they offer plans?
We're starting to see much more, not only limitations in the number of physicians and hospitals, but also geographic limitations in what the plans are offering. So I think you're going to continue to see more limits, fewer benefits, and ultimately higher costs.
Wow. Well, will the individual mandate be more or less popular as we go downstream?
There was a recent study just this week showing that the more that people knew about the law, the more unpopular it was. And I think a number of people don't understand the individual mandate is not being promoted by the administration, and it's the penalties are significant, and people feel it's of an affront to their freedom.
You bet. And will more or fewer employers offer coverage for their employees?
If you're a big company and you're looking at the possibility of paying a $2,000 fine per employee instead of $11,000 for employee health insurance, they're likely to have to drop coverage.
Thank you, ma'am. Thank you.
Thank you. Mr. Thompson.
Thank you, Mr. Chairman. Ms. Turner, you mentioned that some folks are going to be hit with more expensive and less attractive policies. What's a less attractive policy?
As Dr. Gottlieb described, the more limited networks, the hospitals.
The which?
More limited networks and the fewer number of doctors that are providing. There were a number of people that are saying even when they get on the exchange, they find they have to make a choice between the hospital that they've been going to or the doctor that they've been receiving. So the limitations on networks and I think they're also going to be very surprised at the high deductibles in many of these policies. The most affordable plans have deductibles of $3,000 and $4,000.
So you weren't talking about what's covered. You weren't talking about preventive care, mental health, drug and alcohol addiction, all of the fact that they can't drop you for a pre-existing condition. That's not what you were talking about as less attractive.
Talking about the consumer's actual experience in accessing that care.
And tell me, you had just responded to Mr. Johnson's question about whether or not insurance companies would want to get on the exchange. Why wouldn't an insurance company want to have access to that marketplace?
I think initially they felt that this would not only be something that they should do as insurance companies, insure people, but also that this was going to be a large new pool of potentially healthy people that they could get on their plans. But they're finding now that the website is so difficult to get on, and has been.
Now, you mean the one in the 36 states that have tried everything?
No one's been able to sign up on the Oregon
not to
exchange
have a
either.
plan.
A number of others are still having trouble. Vermont, Oregon, others. But just the risk pool that they're now seeing of people who are going to get on the exchanges. As I said, I think that the exchanges could very well become high-risk pools. The policies are not priced for that.
So the effort to discourage young people from signing up is having an effect as to whether or not insurance companies will get on the exchange?
Well, the law itself really discourages young people by charging them more.
Dr. Kreidler, thank you for being here and for your testimony. I was impressed with what I heard you say and what I've been able to read in regard to what Washington is doing. And I'm from California, a state that's had similar success. We were out in front. California was, I think, the first state to go after setting up its exchange and to get everything in place so this would work. We've had over 80,000 people sign up already. 25% of those who've signed up are young people between the age of 18 and 34, and I think that's important to note. And we're getting about 10,000 applications a day, so it's working pretty well in California. And when I talked to the insurance folks, one was in my office today, they think it's going to be only improving as time goes on. It sounds like you're having similar success in Washington. I'd like to ask you about the authority that your office carries in the state of Washington. Are you able to negotiate prices for the policies that are on your exchange, or is that done in another arm of the government?
No, it's done through the Office of the Insurance Commissioner.
And what other so you regulate rates. What other regulatory authority do you have? Can you, if an insurance company, if there's a complaint about the cost of a policy, do you investigate that, and do you have some authority to regulate that?
Congressman Thompson, absolutely. We rely very heavily on getting consumer complaints about insurance companies' behavior in the market, so we can do the targeted examinations of those companies to correct where we see deficiencies, such things as making sure that if you have a policy that says we're going to cover certain specialties, we're going to make sure that they live up to those promises. If the rates, when they're filed with us, they have to be shown that they are not excessive. If they are, we talk to the insurance company and are going to be reluctant to approve any rates that are going to be approved otherwise. So yes, we look at it very closely.
And you've used that authority, you've exercised that authority in the past?
Use it very extensively.
And how does that work? Does it work to the consumer's benefit?
Absolutely. I mean, the companies have learned that we play a strong ball game in the state of Washington. They come in with much better rates just to start with. We didn't have the major issues around medical loss ratios, MLR, as it's been talked about, largely
because... Do you have third-party interveners in your state laws? So can a third party intervene and request a review on your behalf?
Not in the state of Washington do we have third parties. I'm the person who's the third party protecting consumers.
Thank you.
Thank you, Commissioner. Mr. Nunes.
Thank you, Mr. Chairman. Dr. Gottlieb, if you could walk me through the process. Let's assume that I was able to log on to the website and it worked, and so in the last couple weeks I've signed up. Do I receive an Obamacare card in the mail, or like what do I have for proof of insurance, right? That's what people really want. They want to carry a card around so that when they walk in to the doctor's office January 1st, they show them their card. So what am I receiving?
Well, there's not many people who we can ask, but presumably you're going to receive notification from the insurance company just like you would in the individual market. And so I'm sure there are some people who are able to get on early who've already received that notification, but a lot of people haven't.
But I'm supposed to get a card, right?
Yeah.
I mean, most Americans carry a card.
Yes.
So do they have the cards yet?
Will they get, do you know?
I think that's going to have to come from the insurance companies.
Yeah, will come from the insurance companies, but have they mailed them out yet?
I don't know if they've mailed them out yet or not.
I haven't heard of anyone, yeah.
Obviously, it would be a card that wouldn't be valid until the 1st of January.
So,
But you'd want it by now, right?
so let's assume that I do get this card before January 1st. I walk into the doctor's office and I show him my card. Is that doctor's office, do all the doctors have to accept my Obamacare card?
No, I mean, you bring up a critical issue, which is it's very hard for a consumer right now, depending on the plan they're in, to find out what the network looks like. A lot of these plans haven't even made network information available to people who've enrolled. I think the only way certain consumers are going to find out what their network is to enroll in a plan, try to test it in January, and if they find out it's not good for them or their doctor doesn't take it, they can disenroll and enroll in a new plan before March, and I suspect you'll see consumers doing that. This information isn't available. We looked hard for it.
So it's likely that I'm going to walk in to a doctor's, Americans will walk into their doctor that they've went to for years, and doctors are going to reject the insurance.
It's possible. I mean, presumably you would hope that most Americans would check if their GP is going to be taking the new policy, but certainly you won't be able to do that with your full complement of providers.
But how are they going to check if they haven't received the card yet?
Call up the doctor's office, and hopefully the doctor knows if he's enrolled in the network. I mean, this is not easy, you're right. And again, these plans are not putting, even to people after they've enrolled, making available the full network information yet. In a lot of cases, they don't have the networks yet. They haven't fully formed them. They're still putting them together.
Sounds like a lot of people aren't going to have insurance coverage come January 1st.
Yeah.
Do you agree with that, Ms. Turner? Mr. Carlson, do you agree that a lot of people are not going to have insurance coverage, that think they were entitled to it or were dropped off of their employer's plans?
Well, I think the critical issue is with the extension of the enrollment, people are going to wait longer to get that coverage than they would have otherwise.
Now,
But the gentleman...
Mr. Kreidler, now in Washington, everything's great. Everybody's got their cards?
Congressman, they do not have their cards, but what they do have, and that'll of course be through a private insurance company, but people will wind up going to any doctor. What they have an interest in is knowing whether they're in network or not. And Dr. Gottlieb identifies one of the challenges we have is making it easier for people to find out if their provider, the one that they rely on the most, which is often going to be a family practice provider, that provider is in network or not. And that information isn't as readily available right now, either through the federal exchanges or, for that matter, even in the state of Washington. But we're working to correct that. One of the things we encourage people to do.
But you've got 3 weeks left.
Yeah, but it means calling the insurance company. If you've gone through the enrollment process, you've identified your insurance company, let's say it's a Blue Cross or a Blue Shield plan or whatever it is, you give them a call and say, hey, is my provider in network for this particular plan. And they're going to communicate. They contact the exchange. They're going to have information too. Probably not as readily available as calling the insurer themselves, but people can find out. It's just a little bit more challenging right now. It's one of the glitches in the system that we're going to work out and make it a much more consumer friendly.
So if I have a Washington State utopian Obama card, does that allow me to get into any doctor in Washington State, or there's going to be some that are going to reject the card?
Well, if you have an Obama card, you probably won't get into any doctor's office because they'll all be at private insurance companies. But if you come in with a private insurance company's card, you can go any place you want to. But if it's out of network, you're going to expose yourself to considerably more cost to you as an individual. It's important to make sure that when you go in, that you're going to maximize your benefits. And one of the ways you do that is to find out if you're in network, and that's where you have the protections.
Thank you.
Thank you, Mr. Pascrell.
Thanks, Mr. Chairman. Mr. Chairman, I just have to begin by taking exception to something that you said earlier, my good friend. You said that there was no Plan B to correct the myriad of problems. You didn't use the word myriad, that's my word, that exists with the ACA. And our panelists have defined some of those problems very nicely. And I think some of them are undeniable. Some of them need to be addressed, go beyond the rollout of the plan. We all know that. But it took us 6-7 years to respond to Plan D back in 2005 to make sure people who were paying premiums were getting some benefit. Remember, between $2,200, $2,300, and $5,200, those people paid premiums, right, Ms. Carlson, Ms. Turner? They paid premiums and got no benefits. Remember that? Oh, it took us 6 or 7 years.
Yep.
Mr. Chairman, here's what you said. You said that there was no Plan B from the Obama administration to correct these problems. I think some are legitimate concerns, and we should all have them. But, Mr. Chairman, you have no plan. In fact, if you watch the last 2 weeks, I see many of my good friends on the other side of the aisle scrambling to put a flawed erector set of disjointed proposals together, many of which have already been rejected. So we're still waiting to see your Plan A. I don't want to minimize these problems, as I said. I voted for the Affordable Care Act. I'm proud of it. I want the law to succeed. And remember, we came together after 2005, and we worked together across the aisle, even though many of the folks on the Democratic side voted against it. And the reason why I think it succeeded over years is that we worked together. You don't want to hear that. You don't want to hear that we worked together. We had the choice. We had the choice to turn our backs, go back to our districts and tell seniors this was all baloney. We chose not to do that, Mr. Chairman. We chose to use the legislation to help educate the people as to what the benefits were from Plan D reform. That's what we chose to do. You chose not to do that. In fact, we have example after example, and I'm glad our good friend from Washington is here today. The fact is that since October the 1st, there's been improvements to the website. Some states have shown, like Mr. Kreidler's home state of Washington, once these technical problems are corrected, it doesn't mean the other problems go away, but it's a smoother sail to the object. Everyone wants the law to succeed. Or do they? My friends on the other side, while they may feign concern now, have been actively working to make health care reform fail. And you can't deny that, Mr. Chairman. You just can't deny that. You want to deprive millions of Americans of health insurance. And I don't think you care any less than I do about those millions of people. Well, let's be straight about the whole situation. Our governor in our great state of New Jersey, the ranking leading member to now in the polls that he's going to be the next president of the United States, he accepted the Medicaid money from the federal government. He got it half right. But I used to be a teacher, and in my classes, you didn't get a passing grade for doing the bare minimum. The governor refused to set up a state marketplace. We need to look at every one of these states, and has left millions of federal dollars in outreach and education funding unspent. If you remember, in the ACA, $3,600,000,000 in federal money for grants. New York State, which has a similar population in terms of the target here as New Jersey. New York State received $369 million. Imagine a governor turning that down to inform and educate the people in his state on something as dramatic as Social Security and Medicare, to at least inform the folks, what they should be doing or what other options are. It would seem to me to be fair. I ask you, Mr. Chairman, as a leader within your party and on this great committee, come over. Help us make it right.
All time has expired.
Or give us your plan A.
I think the witnesses got off easy on that question.
Yeah, I didn't get to them.
Mr.
We're going to have a double
Green
round. We
recognized.
can come around again, Mr. Brady?
Thank you, Mr. Chairman. Mr. Gottlieb, or Dr. Gottlieb, in your testimony on page 8, under the conclusion section, you state that for every consumer that is made better off under this scheme, there will be other consumers that are harmed. And then you go on to state that these people will make out worse under Obamacare. The Obamacare losers seem to be getting short shrift in the political discussions that are going on here. Many of the families are solidly middle class and many struggle financially. Can you expand on that a bit more? Who will be the Obamacare losers under the current scenario of the existing law? And is there any way to calculate, for every one person that ends up with an insurance policy that he or she did not have before, how many are actually getting worse policies relative to what they want as a citizen, as a consumer, relative to what they have to pay in a premium each month, and what the deductible is going to be, and whether the policy provides coverages they don't even want or need? How many of the folks out there are going to end up being losers because they're going to be worse off compared to every one person that will have a better situation?
All great questions. It's really hard to quantify. It depends on the state you're in, certainly, but you can make an assumption that many of the people who are losing their coverage and are going to be forced into the exchanges are being disadvantaged in some way. Certainly, they made a conscious decision to purchase a certain style of plan in the individual market. They're being forced into the exchange and buying a plan that they didn't necessarily want. Now, for many of those folks, they're going to encounter higher costs. In certain states, they might see comparable costs or lower costs, but those are the exceptions. Those happen to be states that had a lot of insurance regulation previously, and now, you know, the sort of exchange environment is comparable to what they were experiencing. But most people are going to see higher costs and have to pay for benefits that they didn't necessarily make a decision that they wanted. We've done some, you know, rough math at the American Enterprise Institute, and generally speaking, and this is a sort of a crude statement, a blanket statement, if you're above 250% of the federal poverty level, chances are you're going to be paying more in the exchange, even with the benefit of the subsidies. The subsidies won't be rich enough to offset the higher costs.
And how much is what 250% of federal poverty? How much is that in income?
$30,000 for an individual, $60,000 a year in annual income for a family of 4. So anyone above that level, there's a high probability that they're going to be in a more difficult financial situation, notwithstanding the fact that some people might argue, well, they're getting more benefits, but they're getting benefits they didn't necessarily want. You know, this goes right up through the continuum. So you think about, for example, a family of 4 earning $95,000 a year forced off their employer-provided coverage into the exchange. That family is now using after-tax dollars to buy a policy in the exchange. If they buy a silver plan in the exchange, they might be looking at a situation where they're spending almost 25% of their after-tax income on health care. Now, clearly, they're not going to be able to do that. But that's a lot of hardship. And I think, you know, we're worried about the people at the lower income bands, but we shouldn't give short shrift to the people who are middle income, higher middle income, who are also being badly hurt here.
Mr. Carlson, with your actuarial background, what's your thought on that question?
Who are the Obamacare losers in all of this process?
Well, I think if you look at the, from a premium rate perspective, and that's kind of the way I look at it, you've made market reforms that have kind of changed how the insurance, private insurance, healthcare insurance is being funded. You've basically, with the essential benefits, you've required that all policies cover maternity and all policies covered prescription drugs. So, you know, if an individual doesn't need those benefits, they're still going to share in the cost of that. You know, from an actuarial perspective, that's a policy decision. How do we want to spread the cost of health care across the individuals who purchase health care? You know, tell me how you want to do it, and the actuary will price it. But you know, to the extent that there are individuals who don't need those benefits, they're going to be paying for something that, you know, is spreading the cost to somebody who doesn't need it beyond what they would actually use for benefits.
Congressman Kreidler, if you look at it from the perspective that we're going to have losers in this entire system once it's implemented, and then you look at the fact that the enactment has 21 new taxes in it that will raise over $1 trillion over 10 years and take that out of the private sector economy. You'll have a whole new governmental regulatory regime that will impact physicians and other healthcare providers. And at the end of all that, according to the Congressional Budget Office, you'll still have about 30 million uninsured people in the United States, which is around the same figure we started this discussion with back in 2008 and 2009. How can any rational person support the Affordable Care Act?
What I'm saying with the current insurers right now, I'm not seeing the kind of rate problems that are being described here. We went to, in the King County metropolitan area, or King County, most populated county in the state of Washington, we went through one of the major carriers there. They had 31 plans. We found that all 31 plans would have wound up, only one of the 31 plans would have actually wound up costing more. I think if you ever tried to identify some people that would perhaps see the price shock that comes along, it would be somebody that is relatively healthy, that doesn't care about having prescription drug coverage, doesn't care about pharmaceutical coverage, or maternity coverage, and things of that nature. But you
Commissioner, I apologize. All time's expired by a long way. So, Dr. Price?
Thank you, Mr. Chairman, and I want to thank you for holding this this hearing. The President and the administration apparently came out yesterday, said they were going to come out every single day for the next 3 weeks with a new benefit of the Affordable Care Act, and so having this hearing is incredibly important because the American people know that there's not a new benefit to this law every single day. And yeah, he said something yesterday that he says in virtually every single time he stands up, and that is that there are no other ideas. If somebody's got a better idea, then come talk to me. Well, Mr. President, we've had a better idea for over 3 Congresses. H.R. 2300 is a bill that gets patients covered, solves the insurance challenges, saves hundreds of billions of dollars, and doesn't raise taxes by a dime, and doesn't put Washington in charge of health care. So, Mr. President, here we are. We've got a better idea. So give me a call. We've asked, haven't heard a word. So my phone number in the office, 225-4510. Mr. President, thank you, thank you. The problem is the President's plan now, as we heard on the yesterday, is to go on offense and blame the Republicans. Well, there's a great plan. You know, if this were pension care or workers' comp or even unemployment insurance, maybe that sounds politically like what ought to be done at the White House. But, Mr. Chairman, this is people's lives. I spent over 20 years taking care of patients. People hurt when they can't get medical care. People's health care is compromised when they can't get medical care. People lose lives when they can't get medical care. This is serious stuff. And so it's not just distressing, to quote my friend from Washington State, it's cavalier and arrogant to have the administration do this. It's cruel and irresponsible to have the administration move in this direction. We talk in Washington speak here a lot, and so I want to drill down a little bit, if I may, with some of you on the panel. We've talked about coverage gap. What does that mean? Dr. Gottlieb, what's coverage gap mean?
Quite simply, people might not be covered. They might not have insurance.
They don't have insurance. They don't have insurance. They had it before. They don't have it now. That's a coverage gap. That means you can't see a doctor. You can't go to a hospital and have the procedure or the service covered. What about back end? We've heard the back end hasn't been completed. Sounds like a medical term, but Dr. Gottlieb, what's back end? What's that mean?
Well, that would be my jargon again. That's a reference to the systems to allow payments to the insurance companies and to the providers. So the front end, people can enroll, but then all the stuff that should happen after that hasn't been built out yet.
So it means doctors and hospitals and other providers aren't yet, there's no mechanism to pay them yet for the services they provide. This ties into a committee hearing in another committee a couple weeks ago that 40% of the website wasn't completed. They hadn't even done it. They hadn't even done it. That's the back end. So folks at home listening, what that means is that your doctor won't get paid. If your doctor doesn't get paid, you know what happens. He or she can't see you. Network information. Mr. Kreidler used network information. We didn't have the network information complete. Ms. Turner, what's network information?
Well, one would assume that that is the networks of doctors and hospitals that people would be able to see if they were to sign up for various health plans.
So we're asking the American people to make a decision about the most important thing in their lives, their health care for themselves and for their family. We don't even have the information available to them to allow them to make a responsible decision. You talk about cruel and irresponsible. Ms. Turner, you were another question was asked of you about young people being discouraged to sign up, and you weren't allowed to continue your answer. Would you I think you started the law discourages, and then you were cut off. Would you expand on why the law discourages young people?
I think this is such an important issue because it shows that the law needed to be thought through better, because young people were the very people that the exchanges need to attract to the plan, because they're being told they have to pay a higher actuarial price for their health insurance in order to be able to have older people pay less. So you need to have them in, but they're figuring this out. First of all, if they're young and healthy, they're not going to spend 3 or 4 days a week trying to get through a website for insurance when they find that they're going to have to pay more for it than their actuarial
So huge financial disincentive
Yes.
for young, healthy people to sign up. And that's in the law. The Republicans didn't make that up.
Right.
That's in the law. So we got, Mr. President, we got a better idea. H.R. 2300, I look forward to your call. Thank you.
Thank you. Mr. Smith is recognized. Thank you, Mr. Chairman, and thank you to our witnesses today. I know that as we deal with what has been noted by many as a very serious issue, I hope that we can bring about a system that is patient-centered, where the government doesn't stand in the way of patients and their care. And some patients find care in different ways or at different levels, but the patients, I hope, would be in charge. And so I'm very concerned on the very topic that was just mentioned about the need actuarially for younger, healthier folks to sign up who were not previously signing up, and to spread that risk. And yet there are indications that these younger folks are not signing up. Congressman Kreidler, could you disagree with that? Is that not the case?
Congressman, I would agree right now that we're not attracting as many of the young and the healthy that really need to be a part of the Affordable Care Act, because insurance only works if you have good risk and bad risk, and if they have good risk, you need to balance it out. It's the only way insurance works.
And do you think that those targets are being met?
The targets currently are not being met, and one of the challenges that make it more difficult are all of the controversy around the Affordable Care Act. Such things as canceled policies and the like only wind up offering more distraction, and we need to make sure that people are incentivized, realize they have an obligation for personal responsibility, and do the sign up for health insurance so they don't have to have their rates paid for effectively by other people who are insured.
So, Mr. Carlson, if these folks aren't signing up ultimately, what is at risk?
Well, I think what's at risk is the future of that risk pool. The premiums that were set for 2014 assumed a certain mix of younger and older individuals. If that mix is not met, you have an issue that the insurance company is not going to be collecting enough premium relative to the claims they expected. And that also is going to drive their pricing for 2015. So, you know, unless they can see that the risk pool will change to be a more balanced risk pool, they have to build into their pricing the assumption that they're not going to be able to enroll those younger individuals and are going to have to increase their premiums to reflect that difference.
Are there any numbers that you could maybe point to in terms of what expectations? I mean, it's probably difficult to do, but any rule of thumb?
You know, I think that at this point it's way too early to make any judgment. You know, I think it's certainly a positive number and not a negative number, I'll put it that way.
Okay. Well, I just have such extreme concern that if young people weren't signing up before, and they will be faced with a higher premium yet because of all of the new mandates and the government, and the heavy hand of government, I would add, intervening, that will result in a higher premium. I can't imagine that human beings would be more anxious to sign up for that, and even with some of the penalties in place. Congressman Kreidler, do you see any objection there?
You know, one is that there is the opportunity up to the age of 26 of staying on your parents' policy. The other is that there are catastrophic plans up to the age of 30 that are much more affordable, that are possible for younger and healthier individuals to sign up for. So there are some options out there to help bend that cost curve down for the individual, cost curve from the standpoint of how much it costs them, but nobody's immune from bad luck. Even a good friend wound up with her son having a skiing accident in Utah and wound up costing her something like $20,000 because of a broken leg, and he didn't have health insurance. Well, mom went out there to pay for it. Now it's going to be easier to make sure that he has reasonable coverage than it has been in the past. But yes, it means exhibiting personal responsibility so that we work to avoid the fact that if you wind up with bad luck, you don't have to cost shift to other people.
Okay, thank you. I'll yield back.
Thank you. Ms. Black?
Thank you, Mr. Chairman. I want to go to the topic of security. And so, Ms. Turner, this question is going to be for you. We are learning that HHS never built security into the website. As a matter of fact, there was a top security expert yesterday on CNBC that stated, and I quote, "Putting your information on there is definitely a risk," and he was talking about the website. As a matter of fact, there was a piece on there that actually said, and I paraphrase, that there was no expectation of security of your information. It's since been removed from the website. I don't know that we can be confident now that something has changed since the removal of that. But is it fair to force people to use this website, the individual mandate that forces people to buy insurance that maybe they don't want, and to expose them to the fear of having their most personal information hacked? Do you think that would be a concern?
It's a huge issue, and it's yet another deterrent for people to go onto the website. I'm not an IT expert, but I certainly have read a number of them have said that even with this last push, this last roll of fixes, that they did nothing to improve the security of the information that people are required to put on this website. This is a huge amount of personal information that people are required to disclose in order to see what subsidies are available for, et cetera, as well as ultimately credit card information, bank account information. And if hackers can so easily get into the system, it is yet another deterrent from people enrolling in this coverage. I think that has to be a priority.
Thank you. And I would say, given the many problems that have already been identified, that this may be another one that would indicate there's a reason for a delay in the individual mandate as there was for employer delay. Mr. Kreidler, I just want to go to you because you have built a website. And what did you do to ensure that there was security information on your website?
We had a number of protocols that were required of us. One, even for receiving the federal grant, was an obligation to be able to demonstrate that this information would be treated confidentially. And going forward, we had an obligation to make sure that the system operated. But, you know, all websites. I mean, we've certainly seen it with some of the major websites in this country where there's been compromises that have taken place, private websites that have had problems with personal information. I think it's an ongoing obligation and a challenge in the new era of websites and the kind of information that can be accessed is to build in as much security as possible.
So you say that in order to receive the government grant to build the website, you had to ensure that you would use, I would say, probably standards that are accepted within the industry to ensure that, such as the end-to-end testing. Did you do end-to-end testing on your website?
We did do testing. I wish we had done more testing, just from the consumer perspective more than the privacy issue. But part of this is even though we have our website at the state of Washington level, you have the federal hub that you also interact with, which goes to a lot of the more critical personal information that you're describing, whether it's IRS information for eligibility or whatever. So it's a complex system that, and confidentiality is something that we take very seriously.
Well, and thank you for that. And I would say, given the fact that the federal government required you to use industry standards to ensure that you did end-to-end testing and to ensure the folks that are using your website that they could be confident in putting that material and that at least you did all you could to protect them, that is certainly a disappointment that the federal level did not follow those same standards because we know that they did not do end-to-end testing, and so this is a big concern. With the little bit of time that I have left, income verification has been something that I have been very concerned about because the two planks of the ACA was that if someone did not have employer-sponsored insurance, they could apply, and when they applied, we would have to verify income to be sure that their income was at a level where they were eligible for these tax credits. We learned yesterday that the Inspector General for the Tax Administration, and I quote, "The IRS existing fraud detection system may not be capable of identifying the ACA refund fraud or schemes prior to the issuance of tax return funds." So now we've got another situation that was not set up or being followed where we don't know how much fraud is going to take place here. So thank you very much, Mr. Chairman.
Thank you. Mr. Reichert is recognized.
Thank you, Mr. Chairman. Thank you for allowing me to be a part of this hearing and pose some questions. And I would feel a little bit guilty, Mr. Kreidler, if I didn't attend. I'm not on the Healthcare Committee subcommittee. I now am on Human Resources and Trade. But I think as a fellow Washingtonian, I wanted to be here along with Jim McDermott and yourself. So thank you for coming. Thank all of you for your testimony. And I know you're proud of the product, and I know you've put a lot of hard work into the Washington State exchange system. But I just want to be here to bring a little bit of reality to it. And I think you've touched on some of those things, but I want to highlight some of the issues that we've had. You know, my good friend from New Jersey has said, look, you know, we're looking for this to work. And what we want, though, really, is quality health care, affordable health care. We want access, and we want the freedom to choose. And I think that in the Obamacare plan, which we oppose because it hasn't lived up to any of those promises, in our opinion. That's why we're working to correct this, because these are the things we should all be, it's not just about making the law work. These are the things that we should be after, right, for our constituents. So I know you're proud of your work and proud of the fact that over 176,000 people have enrolled in the Washington Exchange program, but out of those 176, 158,000 of those are Medicaid enrollees, only 18,000 are individual enrollees, and isn't it true that if that number doesn't go up by 2015, that the health insurance providers will have to increase their premiums for the losses that they are going to incur if they don't get those individual enrollments up?
It is an ongoing concern because we obviously want to get as many people enrolled through qualified health plans through the exchange, people who will be eligible for subsidies and some that are not eligible for subsidies, but also signing up for plans.
Isn't it true, though, sir, that premiums will probably go up if those numbers don't rise?
You know, as Mr. Carson's pointed out,
yes?
as an actuary, the answer is it's too early to say because you're only going to have about a quarter of a year in order to make those determinations. There's a lot of other pressures that apply, such as market share and competition that are going to drive insurance companies that help to hold down the rates.
I agree that there's some time yet, but it looks like from the information that we've been able to gather, the premiums will go up if those enrollments don't go up. The other issue is the 8,000 people who had a subsidy issue. They enrolled in programs, discovered that their subsidies were incorrectly calculated. I think you're trying to address that problem, but once they now have discovered that their subsidies are less than what they supposed in the first place, now their premiums go up and they have insurance plans that they didn't want or doesn't provide the service that they need. I think that's a huge issue. 8,000 people, you talked a little bit earlier about glitches. Glitches mean people to me. That's 8,000 people that are in a glitch that needs to be fixed. 290,000 people in Washington State received notices that their insurance plans were canceled. 290,000 people in this glitch. The president said after he made these promises, you can keep your health care plan, which was really not totally truthful. Finally came out and said, you can keep your health care plan. The House of Representatives here in the United States Congress passed a law that said you can keep your health care plan. Harry Reid did not bring that bill to the Senate floor. You decided, sir, to separate yourself from the president on that request and decided not to allow those 290,000 people to keep their health insurance. Did you speak to any of those health insurance carriers to see whether or not they could continue their coverage before you made that decision for those 290,000?
The answer to that, Congressman, is no, I did not.
Why not?
I regulate.
Why did you not contact those insurance companies?
We had a statement from the American Health Insurance Plans, that AHIP, that it was very clear that they were distressed by. The irony of it is they were distressed about what the president proposed, but they privately would have said that the Upton measure that passed here.
Well, before my time runs out, Mr. Cardler, I want to make a couple more points. Soon to hit now will be the employer mandate or the employer small businesses association plans. They're going to get their notices for cancellations. I know that some already have. The other thing that really bothers me is this narrowing network issue that you spoke of earlier in your testimony. Look, we have plans in there. Only one insurance company covers the Cancer Alliance, Children's Hospital, University of Washington's Hospital. Thank you, Mr. Chairman.
No, thank you, Mr. Reichert. First, let me recognize Dr. McDermott for a unanimous consent request.
Mr. Chairman, thank you. I ask unanimous consent that we enter into the record a letter from the Association of Washington Healthcare Plans dated December 2nd, 2013. It responds directly to what Mr. Reichert is saying. It says, accordingly, if the administration of Congress chooses to make additional policy changes in the ACA, we ask that you advocate for allowing states with functioning state-based exchange, like Washington, to continue with implementation as currently required under ACA.
Right.
The insurers in Washington State ask him not to make the change.
Without objection, one, I'd like to thank our witnesses for their testimony today. There are a lot of concerns about this law. A lot of families and patients and local doctors have concerns. We're going to continue. I think your testimony was insightful. Your answers were thoughtful. I think, very helpful in this whole discussion. We'll continue to do oversight, vigorous oversight over this law for Republicans and Democrats to be able to make sure we know what that impact is. As a reminder, any member wishing to submit a question for the record will have 14 days to do so. So if any questions come your way, I'd ask that the witnesses respond in a timely manner, as I know you will. With that, the subcommittee is adjourned. I'm sorry. Bill?